going to be discussing on the imperative of digital health innovations and technologies for accelerating our progress to universal health coverage, and looking into the interoperability of digital solutions, again the robust training and skilling which is required as we enter this digital transformation, putting in our financial resources for looking into and adopting these new technologies, IoT, AI, machine learning, all that. A lot of resources, financial resources need to be put. Training and skilling is required of people to be operating these digital technologies, having a more people-centric system, and how digital technologies can actually help us leapfrog and bring in more integration of the patient and the doctor, the cities and the remote villages, integration more of the public and the private. Also, we have some success stories which are going to be shared, how the adoption of digital has actually helped in taking the quality healthcare to the citizen at the last mile, how we can leverage on this opportunity of digital transformation, of digital India. That's what we are going to be broadly discussing. And then the biggest example of digital and how it has been able to make an impact has been during the COVID times when everything was shut, how the use of digital technologies, we saw the CoWIN platform, how through the CoWIN platform, the government-driven platform, how we were able to administer vaccines, reach out to people, again with the digital innovations, the digital technologies. So going forward, digital is the way. And the session looks into the pathways to scale up the digital health adoption. Thanking our sponsors of this session, Neotia Get Well, our partners, knowledge partners, PwC, ADL, and NASSCOM. This is a joint session of Nathealth and NASSCOM. So I think I'll just invite Dr. Shravan Subramaniam, the President of Nathealth, who's leading this session, inviting Mr. Sanjeev Malhotra, the Chief Executive Officer, Center of Excellence for IoT and AI, NASSCOM. Our keynote speaker, Shri Kiran Gopal Vaska, the Executive Director, IT Policy and Coordination, National Health Authority for Pradhan Mantri Jan Arogya Yojana and for the Ayushman Bharat Digital Mission. He has implemented government initiatives and coordinated the efforts of various international organizations in order to improve the healthcare service delivery. We'll have a presentation on the challenges in the Ayushman Bharat Digital Mission stack adoption and the solution framework to improve adoption. That's by Mr. Barnik Chitran Maitra, the Managing Director of ADL India and Southeast Asia. As we'll move into I think we'll cover this and then have the panel discussion, and then I'll invite the moderators of the session. So Mr. Sanjeev Malhotra from NASSCOM, he is currently building the innovation ecosystem with startups, with corporates, government, academia, focusing on various emerging technologies. And he's going to be sharing with us more on his views on the Ayushman Bharat Digital Media Overview and its adoption. So with that, I request Dr. Shravan Subramaniam to kindly set the context of this session.
Thank you so much. I think we should have set the tea and coffee here. We'd have had a fuller house. But I think they'll start trickling in, but we should get started. This is a very exciting and important topic. And we've been talking about this in some way or the other, practically in every session, right from when Dr. Paul was here. We've been hearing across the sessions about the importance of scaling up and skilling up when it comes to healthcare delivery, better clinical outcomes, better for business, and whatever we can do to support connectivity, to support exponential access. And whether it's scale or skill, digital health has a very, very significant role to play. We've been talking about this being our UPI moment in healthcare, getting everybody on the bandwagon when it comes to interoperability and portability of healthcare data with necessary privacy controls. And we have a booth from the government just outside that all of you can look at, learn from, and get your organizations to be a part of. But what's also very special for us as Nathealth is this is the first time we're collaborating in a big way with NASSCOM. So it's my absolute privilege to invite and introduce Sanjeev Malhotra, who heads NASSCOM, as our partner organization for this event, and to take this away. We've had our MC has given the overview of this, so I'll not go over it again. I'd like to invite Sanjeev to take over and run the session. Thank you, Sanjeev.
Thank you. Good afternoon, everyone. What a privilege to be here at the Nathealth platform, one of the most prestigious and the largest when it comes to the healthcare providers and the ecosystem it represents. I come from the background of technology, having led this innovation initiative started by Government of India, the Department of IT and Electronics, MeitY, Ministry of Electronics and IT, and state governments with the objective of bringing out newer innovations in the emerging technologies and applying it to the different sectors. And when I talk about sectors, the healthcare happened to be our top priority for multiple reasons. First of all, it is an important sector when it comes to the government priorities. And the second one, that there is a lot of innovation and a lot of good solutions, a lot of startups, a lot of companies who are working in this sector, working on newer solutions, and there's a lot more impact also it can create when we talk of these solutions. I mean, why are we talking digital? I mean, it is obviously, we have seen what digital, the impact it has created when it comes to payments, when it comes to some of the vaccines, some of the other programs that are happening in the country, and a lot more are happening in the sector of commerce and logistics and so on. We are moving from the concept of platform to the network, and for which we have privilege of having, you know, Shri Krishan Gopalji from NHA. I think it's a pleasure to meet him here again. We also have Barnik with us, who brings a vast consultancy experience when we talk of digital. Just to give you a little idea of the projects that we have taken up, we work at two levels. One is how do we take some of these, first of all, I mean, let me give you a little more background. I mean, we have a fairly vibrant startup ecosystem in the country. We are the third largest startup ecosystem in the world. And if I break that down and bring out the deep tech startups, when I say deep tech means the cutting edge of the technology, there are about 3,000 of those in the country and growing at 10%, which is a fairly good number. And these are the startups which are spread across different sectors. And out of the 3,000, I would have a rough guess of something around 500 are in the space of healthcare technology. And much larger number if I bring out all type of startups in the healthcare technology. And they're all working in diagnostics, curatives, patient care, hospital optimization, digitization of different processes, radiology, image recognition, and so on. It's a pretty vast set of areas that we have our startups where they are focusing on. And we had, the other good news is that the willingness on the part of providers to work with this solution is also going up. We are a very risk-averse nation as such, right? We always want tried and tested things. But I think the overall foundation that has been laid out by the government, by the other projects, is definitely helping changing minds. And a lot of them have actually come on board when it comes to the adoption of digital solutions. And they are not just limited to medical areas. There are solutions where some of these largest companies of the world, based out of Germany, based out of US, have come to us, say, how do we train our sales force? in the times of COVID. So they have taken up solutions from our startups which have got deployed in Germany on how to do remote training of these resources. Similarly, they have come up with, we have had experience of adoption of solutions ranging from AR/VR solutions of remote working to as well as to solutions which are in the AI predictive and image recognition when it comes to imaging and so on. So with such kind of resources and innovation at our hand, I think we need to work together in growing this so-called innovation ecosystem. And I'm happy that we are partnering with Nathealth on this initiative. This is a beginning, and this is going to continue throughout the years. And I will like to invite all of you to be part of this initiative in whichever way you can, and we'll be happy to take this on and grow this. So with that, I would like to invite our next speaker. As I said, we are privileged to have Shri Krishan, sorry, I got your name wrong, Kiran Gopalji. We had a privilege of having him in Bangalore when we hosted a large technology event. I mean, they are driving one of the largest initiatives when it comes to digitization in healthcare. You will be amazed to see the amount of work that has gone into it and the impact it has created. And so many of our startups are already on to your initiative. So with you, I'd like to invite you here for your address. Thank you.
Thank you very much. In fact, it's a privilege to be associated with a mission like this that has a potential transformative effect on how healthcare is delivered in a country like ours. And I was asked to talk about ABDM in general and also how we are trying to increase the scale up and adoption of ABDM in the country, what approaches we are taking. So I'll briefly, for the uninitiated, just take you through what ABDM is all about in just a couple of slides. Some of you may have already seen it, but it's always good to just recollect what this is all about. So the vision of ABDM was basically to create this national digital health ecosystem with the ultimate aim of achieving universal health coverage. And as part of it, a certain technology and policy level decisions or frameworks have been followed, where we say that there has to be this idea of single source of truth. This is where the building blocks of registries come into picture. Then there is this idea of federated architecture, where we say that data stays where it is created. We are not creating one single repository of data, or government is not trying to amass everybody else's data, everybody's data to do certain, use it for any other purpose. Then using the idea of open APIs and interoperability. I mean, it is a fact that if you were to create something of national scale, create this kind of an ecosystem, you would need partnership and you need buy-in from every other stakeholder in the country. So that is where an open API-based architecture with interoperability of the core comes in. And the India Enterprise Architecture Framework guides this entire work. On the policy side, privacy and security by design, because we are dealing with sensitive health information. User inclusivity. I mean, we are talking about different types of users, right from very advanced smartphone users to someone who doesn't even have a phone. We don't want to exclude them in any way. Participation in the whole thing is voluntary. We are not saying that you have to come and do it. In fact, we would like to create a situation where you are losing out by not being part of this. And finally, to move from disease-centric approach to a wellness-centric approach, which is more holistic in nature. I mean, if I were to just tell you in a minute or a minute and a half about what ABDM does, I mean, there's the whole stack, there's the whole architecture about it. But simply put, we do just three things. One is interoperability of health data. Your health data should seamlessly be able to flow from one entity to the other entity with your consent so that you get the best possible care. Second, interoperability of health claims. Insurance, as we all know, is an important aspect of the whole health space, and digitizing this and going to a situation where from current state of full manual adjudication to auto adjudication, so that the processing time, the costs, etc. are reduced, so that today where we are talking about insurance only in the IPD section case, we can also think about insurance for OPD. And lastly, interoperability of services. You want to consult a doctor, you have to be on the same app as the doctor is in, at least today. We want to break that. We want to say that you use an app of your choice, let the doctor use an application of his or her choice. You both should be able to find each other. You should be able to book a service, get an appointment, avail the service, and pay for it. So this is what the unified health interface does. So these are basically 3 things that we are trying to do in the digital mission. These are the building blocks. Some of you already know it. The unique ID or the ABHA, the Ayushman Bharat Health Account, professional registry for professionals, the facility registry for registries. These are the single source of truth that we talk about, which actually give that credibility to the ecosystem players that are talking into, because these are all verified entities who are participating in the ecosystem. And then the consent manager, which is at the heart of the information exchange, which helps you in moving things data from A to B with the consent of the patient by using the consent artifact created by Government of India. And the unified health interface and HCX are both 2 entities which help in interoperability of services and claims. And in terms of achievement, yes, a lot has been said about what we've achieved. Yes, every 4th Indian in the country today has an ABHA. We have been able to link more than 25 crore health records already. So the momentum has picked up. And believe me, it took us almost a year to reach 1 lakh. Just about 4 months to make it 10 lakhs, 2 months to make it 1 crore, 1 month to make it 10 crores, and then we just took off. So if you really look at hockey stick, it's really a vertical, like a proper hockey stick. So we have been able to create and build that architecture which is ready to bring in players and start playing on this and using this ecosystem and take the benefit out of it. Now the next question comes is, how do you scale it? How do you make sure that every entity participates? How do you create value for the ecosystem players to be part of this? So the interoperability and the privacy part that I've already spoken, this is about how 2 entities of health information and user and health information provider interact with each other through the consent manager by making use of the registries that have been made. And we use the standard FHIR objects for data interchange. So this is how the architecture is in place. Now, in order to create that push, in order to create that impetus where people can start adopting ecosystem, digital health solutions, we at NHA are trying to promote easy-to-use digital solutions that are cloud-based, using QR code-based consent and sharing wherever possible, standard terminologies like ICD-10, SNOMED CT, etc. Because when we talk about interoperability, there are 3 layers, right? One is the transport interoperability, where you are just able to send a data packet from A to B. Then there is a structure interoperability, where you are able to just decipher what A, B, C entities are coming to you. Finally, there is semantic interoperability. You should be able to make sense of what has come to you. So standardization and using standard terminologies can help us achieve this, and that is the ultimate goal, where your machines can actually start using the AI ML techniques and tools to create useful information out of data, and we can reach that ultimate goal of auto adjudication, which ultimately can bring down the costs in providing service. Intuitive UI and UX, you should feel like using it. Any UI, that is what even government solutions are blamed for, saying that it's not very user friendly, etc. We are promoting creation of user friendly UIs, apps that are web and app enabled, solutions that are multi-tenant, offline solutions. Like I said, this inclusivity is an integral part of it. Modular, so that one need not have a monolith solution where I don't really need certain features. I should be able to choose what features I need, and a microservice based architecture. So this is the kind of solutions that we are trying to promote through various means, so that people start adopting digital solutions in the health space. Now, the ecosystem, as we all know, has diverse stakeholders, and each one of them needs to be uniquely handled. Citizens, the ultimate beneficiaries, you need to create value for them. You need to create a reason. You know, when Aadhaar was being made, people didn't know what the whole point was about getting a number. It couldn't prove that you couldn't prove that you are a citizen of the country by using Aadhaar, because it was a number given to any resident. It didn't get you any PDS or ration. It didn't get you any health benefit, nothing. But then we started looking at the value of it only when eKYC started. Now, today, billions of eKYCs are happening, and the kind of value it is bringing in is only when people are able to realize the use of Aadhaar. Even in the health space, even in this digital mission, we need to create that value and create that interest so that people feel like using it. I don't want to wait for 2-3 years down the line when I want to see some benefit. So how do you engage them? And at the same time, educate them about this whole thing. And this is not just about you going and thinking about your digital health solution at when you get sick. The whole wellness-centric approach. I mean, today the ABDM ecosystem or the architecture is built in a way that we can capture data from your health devices or your smartwatches and other such devices. So the idea is to have a wellness-centric approach. And on the regulatory and accreditation bodies, see, these bodies have been there for quite some time now. They have been playing a role. But then when digital health comes into picture, there is a certain amount of what you call clarity to be brought about what kind of role they would be playing. I mean, what is digital health health is going to be like? We know health is a state subject. Center does not create any legislations. But at the same time, when you talk about digital health, I mean, can we talk about, say, because electronics, information technology is a central subject and health is a state subject, can we think about saying that e-health can be a concurrent subject? So how about bringing about such regulations and trying to rope in all these bodies into it? I know it says time's up, but I believe I have 15 minutes, right? So I'll use the remaining 5 also. So the pharma industry, the non-profits. So these are non-profits we have realized during our adoption process are some of our most invaluable partners. You know, when we are trying to implement something, demonstration effect is probably one of the important things that we have to think about. So the idea of microsites. So in Mumbai, in Dharavi, we have picked up 5 wards where we are actually implementing this solution, where these digital solutions with one NGO, where we are saying that every small clinic in that area will use a digital, ABDM-enabled digital health solution. Every patient visiting there gets his or her ABHA created and his or her records generated. So, and we are expanding it further. So this, as NHA or as, for example, a state authority, we may not be able to achieve. So partnering with NGOs and such organizations is an important part. Healthcare providers, they come in all shapes and sizes, right from a single doctor clinic to the large corporate hospitals that we have. And interestingly, the marginal effort that one needs to put in as a large corporate chain into becoming ABDM compliant is far lesser compared to what a small single doctor clinic would have to put. He'll have to buy a computer or a laptop, then buy a software and do that. But the fact is, adoption is quicker by the smaller guy. More questions are asked by the bigger guy. So you need to have a different set of gloves to deal with these entities and how to bring them on board. Because at the end of the day, we want everybody to be part of this whole ecosystem. Insurance, like I said, this is one industry probably that is most looking forward to digitization of the health space because of the benefits it is going to bring about, because of the kind of proliferation that can happen on account of this digitization. And then health tech companies, the most invaluable partners, these are the ones who are going to take the whole thing ahead. And at NHA, right from the days of National Health Policy to the health stack to the digital health blueprint, the idea has been, we build the rails, you run the trains. So the idea is to create the ecosystem and foster an innovation culture where the innovation from the private sector comes in, where partnerships with entities such as NASSCOM, Nathealth, every other entity can actually help us in actually pushing and helping the tech companies come up. And then the government, both federal and provincial level, the state level interaction and trying to bring them and roping in is also another challenge. So to give you a few examples of how we are trying to incentivize or try to pull people into using it, we've recently launched the Digital Health Incentive Scheme, which says that if you are a healthcare provider and if you are creating an ABHA and linking a record, for every record you link, we'll give you 20 rupees. If you are a diagnostic lab or a facility, again, if you are linking one record, we'll give you 50 rupees. And if you are a digital solution company, for every record that is being linked on account of using your software, you get 25% of what the provider is getting. Of course, there is a cap of 4 crores, but that we believe is a decent amount of money. We have a large number of providers who have currently registered and the scheme is currently on. In fact, we are trying to liberalize it in more and more so that more and more people can taking benefit of it. But at the same time, I would like to say that this is not going to be a sustainable thing in the sense that we can't keep disbursing money forever. We can't spend $40 billion like what the US did. But at the same time, we feel that that initial step of coming in, the stickiness that we can bring about by making people realize the benefit of using this solution through this incentive scheme is something that we want to leverage on. Next, outreach program to promote ABDM adoption. I mean, targeted outreach programs to health professional bodies, hospitals, diagnostic labs. We also came up with an idea of a minimum viable product, where we said that if you have A, B, C, D features, we say that you are minimum viable, and we list you on our web page, and we also help you in your marketing. And we are also saying that as a health tech company, if you are able to find your solution and you are selling it to somebody, then we will provide you the L1, L2 support, provide you a separate call center number, so that, and then we take on that burden as long as you want to do it or as long as the policy continues. And then at one day when you are big enough, you can probably take over that thing. Similarly, rewards and recognition and outreach events are something that we are trying to do to push adoption of ABDM. And those who are integrating with us, the tech companies, the solution, HMI solutions, I mean, beginning with support for onboarding onto the sandbox system to open house sessions and workshops and understanding the APIs and architectures. We are also going on to one-to-one technical discussions, dev forums, etc., to make sure that you have the best possible support in order to be part of this ecosystem. Because initially it might be intimidating, but once you start, it becomes very simple. And when you learn from your peers, that becomes even more interesting and easier. Lastly, like I said, creating that use cases, creating value for the end user. And this is where private sector innovation and innovation from the larger ecosystem comes in, and where we say that, how do we find those use cases that are interesting? And scan and share is one such use case where some of you know about it. Simple thing is, you go to a government hospital, you want to get yourself registered. What do you do? You just say your name, age, gender, and what problem is there. For that, you have to stand in a queue for 1.5 hours. We are saying, why not scan a QR code, get a token number, wait, and then when your number comes in, your information is already pushed. Just go tell that I have a stomach ache or a fever or something, and it tells you go to the next page. And then we are extending it further to payments, to record sharing directly using QR codes. So as you can see today, this is implemented in 27 states where 437 hospitals are using it, and close to 1 million people have already used it. And everyone is saving at least an hour and a half by doing this. And more importantly, the health tech companies, the PHR applications are reporting back saying that once somebody uses scan and share, they've never deleted their app. So that is creating the stickiness. And 40% of the people using it are second-time users. So the usability, you're getting used to it and you're finding the benefits in it. So finding more and more such use cases is also key to increasing adoption of the digital mission at the country level. So I think these are some of the steps, and I think forums like these and events like these are where we also try to learn and understand from you what are your expectations, so that we tailor it, the ecosystem, and tailor the architecture in a way that makes things easier for you to be part of the system. And as a result, today, as you know, close to 100 entities are integrated with ABDM, which ranges from LMI solutions, HMI solutions, government programs, health tech providers, insurance, health lockers, and PHR apps. Many more are yet to come because we are yet to reach there. It is estimated that close to 600 crore health transactions happen in our country every year. That comes to about 2 crore transactions a day. As of today, we have reached a state where we were able to link 72 lakh records a day. So that is, the system has proved its stability. The idea is, and on a consistent basis, we are linking close to 25 lakh records a day. How do you increase it by 8-fold? How do you bring in more and more hospitals, both public and private? That is the question. So these are all the approaches, and I'd like to, in fact, learn and understand from all of you as to how best we can take this forward. Thank you so much.
Thank you so much. I think, as I said, it is amazing, and at the same time, we take pride in the fact that we are moving towards digitizing our healthcare system, which is by far, I think, the biggest and the most complex, and I think the results have started showing in, and wish you all the best. And I think we'll also like to hear from you after our next session as to what people sitting in this room can do to promote this further, right? So with that, I think I'd like to invite our next speaker, Mr. Barnik Maitra. He's the managing partner of ADL India. He'll be talking about the challenges in the ABDM stack adoption. And after that, probably we'll spend a few minutes talking about what all we can do. We have some of the people who really have insights into the healthcare system, and some of them run some of the largest institutions in the healthcare. So we'll have that discussion after your session, Mr. Barnik.
Good afternoon, Sanjeev. Thanks for the introduction. Shravan, it's a pleasure as usual to partner with Nathealth to do another report on digital health. Kiran Gopalji, it's so inspiring to hear you again, because every time I see your presentation, ABDM has moved.
The existing ABDM architecture, the specifications, the UHI, etc., is something that we want to take it further and build it, and we want, you can partner with us in different firms. I mean, if you are a health tech company, integrate with us and try to tell us how best to help others integrate. Maybe you can build an adapter that makes integration with ABDM easier, cheaper, and faster. So that's one thing. If you are a hospital, try to evaluate solutions that we've onboarded as minimum viable products, where we have also listed on our webpage, and tell us what works and what doesn't work. So I think these are all a lot of things that we can do. And then word of mouth. I mean, although they say that close to 70-75% people know about ABDM. Knowing about ABDM, what digital mission is one thing. Actually starting to use it, and has any one of us tried to use a PHR app, try to download a record and see what it looks like? Try for yourself. You will see the benefit, or you will see what is good or bad about it. Tell us, write back to us, and we will try to improve it further.
Right. No, thank you so much. I think this was wonderful. And just to appreciate the work happening in our hospitals or healthcare providers, we run this program called Healthcare Innovation Challenge. When we started it 2 years ago, first edition, there were only 2 or 3 people who came forward. And now in the 4th edition of this Healthcare Innovation Challenge we have 6, and there's a demand for 3 more. So that's the level of demand that we see for digital solutions and awareness, and people are willing to try and risk few things also. So I think we have all positive indicators and trends. With that, we thank Shravan, Barnik, Mr. Gopal for being here, and like to call the next panel, for which you will do the honors. All right. Thank you so much.
So thank you to our distinguished speakers of this session. And thanking once again Shri Kiran Gopal Bhaskarji, Mr. Sanjeev Malhotra, Mr. Barnik, thank you. In fact, this session has given us a lot of insights into ABDM, the digital adaptation, and how digital solutions can help us in scaling the progress of universal health coverage. And we are going to be now discussing deeper into it, moving with this panel discussion, how digital technology can help in reimagining primary care in post-COVID era. Also going to be showcasing some success stories of the digital technology enhancing access to care and addressing challenges and possible solutions in adopting digital technology. I invite our moderator of the session, Mr. Neeraj Jain, Country Director, Program for Appropriate Technology in Health, that's PATH. He is a member also of the CII's Nutrition and Public Health Committees, also of the Food Fortification Committee. 30 years of leadership experience he has in strengthening organizations. Our speakers of the session, inviting Mr. Girish Krishnamurthy, Chief Executive Officer and Managing Director of Tata Medical, Mr. Prabhat Sinha, Director of Public and Government Affairs, Boringa Ingelham India Private Limited, and Ms. Ruma Banerjee, the Vice President of Ambuja Neotia Healthcare Venture Limited. So 35 minutes panel discussion. I hand over to our moderator.
Thank you so much, and it's nice to see time's up. Okay, we are resetting the clock. Thank you. A very, very good evening to all of you. I want to thank Nathealth for inviting me and all these rocking panelists for this conversation. Just a couple of things, COVID kind of brought health equity right up front, and the whole concept of it's not, this two Indias, of some of us who can afford health, some who can't, came up. Universal health coverage became front and center, and I think that's going to be the call to action for the next few years. But to be able to achieve that, I think primary healthcare is going to be right at the center of it. So I'm going to, not waste any time because we don't have much time and I really want to hear from all of you. Maybe I'm going to start with you, Girish, because I know you have been a torch bearer when it comes to primary healthcare. I think the first time I met you was 7-8 years ago when you were running a primary healthcare program up in Himachal, World Economic Forum conversations. So I'm going to come straight to you. Tell me, and now you're working in, digital healthcare, etc., diagnostic. Tell me, how are we going to make primary healthcare more patient-centric? How are we going to actually use digital technology to bridge the gap in this whole patient-centric approach? How, and especially in the situation where we don't have enough healthcare providers, and the slight differences between urban and rural, if you could touch on. So if you could share some of your thoughts, Girish.
Thanks, Nirajan. Thank you, everyone. It's an honor to be here. See, first of all, we have been experimenting very large experiments across India for the last 7-8 years, especially focusing on primary and secondary health. And we have done a lot of work in rural India. So close to about 4 to 5 million, about 50 lakhs Indian citizens of doing a digital health. So first of all, I want to take Niraj. One is the COVID era. What is digital health? Because is it doing a telemedicine is a digital health, or buying an online pharmacy is digital health? I saw some chart coming up in how digital health is getting adopted. So let us look at, from my perspective, what is digital health, which certainly can bring in patient centricity into part of it. See, healthcare is a one kind of a unique area. Culturally is very different. Have you ever heard a doctor calling a patient? So the doctor reaching out to a patient. So the digital is slowly bringing that culture in. And what is, again, looking at calling and booking an appointment in a practo, and then getting multiple SMS and WhatsApp saying that this is the time of appointment, are you coming? This is your bill, can you pay it through WhatsApp link? Is that digital health? Or what we are talking about in ABDM, where you create an interoperable data going between two entities, is digital health? Or having highly intelligent equipment which can scan CT remotely without technicians doing things? Or doing an image recognition and doing an AI is digital health? So today the digital health is a very loosely bound statement. So let me quickly summarize what I think the digital health can provide to the context of India. India's problem is very unique. We have a huge primary and secondary health problem where access and availability is a big issue in rural India. Whereas when you come to urban India, in the top 50 cities of India, we have a huge issue of a chronic care, which I want to define, starting from diabetes, hypertension, to thyroid, PCOD, and geriatrics issues, asthmatic issues, allergy issues. It's all lifestyle diseases. And just to give you one data point how digital health has to really get up today and run very fast. 430 million Indians are expected to be obese by 2030. And the only way we can solve this problem is digital health, which what I mentioned about all the different aspects of it. Digital health helping a patient-centric model. I want to leave you with 5 points so that it makes, in my opinion, this is what digital health is. First of all, digital health should be creating a connected health. And it should be continuous healthcare ability we have to provide. Third, it should be proactive in nature. Fourth, it should be close to patient, both physically and digitally. Last, the method is patient-centric because if you see all the speakers speaking, last 40, 50 years, the whole healthcare is driven by, or is a payer-centric and provider-driven. And there's a shift, and all of this can be possible only with digital health. I'll leave with this high-level thought. If you go a little specific, I can speak about this topic hours together, days together. I'll stop it here for the purpose of the...
I know, Girish. I know you can go on about this, and I'm going to catch you one of these days to be able to do that and learn from you. But you know, as one of my ex-bosses used to say, it's not about digital health, it's about health. Digital is just an enabler. And I think you've sort of hit that nail on the head as you've talked about it. I think it's going to be important as we move forward to try to divide and try to understand what we want to focus on, especially when it comes to primary healthcare. Because, you know, there is a lot of conversation that's happening around primary healthcare. How can we use AI? How can we use digital tools? And typically where it's sort of coming is really focusing on the screening and diagnostics piece. If we're able to screen early through the help of digital technologies or diagnose early, we'll probably be able to treat better. Thanks a lot, Girish. Ruma, I'm going to come to you now. Ruma is the Vice President at Neotia Healthcare and, of course, doing a lot of work within this space. You know, if you think just about the private sector, you know, we've heard from Kiran just a little while ago, very interesting stuff that's happening in ABDM, and, you know, PATH is the organization that I work for, and we're doing a lot of work in that space. But think about the private sector. What are the opportunities? And sorry, I'm going to add one more sentence. 70% of India goes to the private healthcare provider. They're not going to the public health facilities. So if you want to get primary healthcare to universal health coverage, private sector is important. So what are the opportunities that the health systems actually provides for integrating technology in the private sector with such a fragmented private sector? Any suggestions, any thoughts on that?
Yeah, thank you so much. You know, essentially talking from the provider side, if we talk about how this, digital health is really going to help in the private sector. When I say private sector, I'm essentially meaning I'm talking about urban private sector, because we typically talked about, you know, how typically rural India is working and how urban India is working. If you ask me what are the areas digital health can really help, I will say it has at the primary sector, at the urban health delivery system, already a lot has happened. If you typically look at, if we divide it into two parts, one we talk about is a direct, you know, patient connect, another where there is, another is a engagement area. So on the direct patient care, of course, telemedicine was there around, and after post-COVID era, probably telemedicine has actually become a tool, at least for an initial discussion. I'm again telling you, telemedicine will never replace the in-chamber visit of a patient, but it at least behaves as a tool of an initial connect. On the engagement side, if we look at, it started from, you know, if from the provider side, it starts from the information they receive from the provider side, maybe from the website or somewhere. It's the information first through the digital media. Then it starts from maybe from scheduling to, you know, coming to the doctor, and then check-in, check-out, post-discharge communication, having their reports, etc., available at the digital platform. So these are the areas which are actually happening, already happening. Even e-prescription, urban primary care has adopted probably all these areas. Of course, there's a lot to go. I'm not talking about the homework which we'll have to do, because there are areas where there is issue of connectivity. I'm not talking about the products which at times does not really come up with a really, a great ROI proposition, because every healthcare segment, as you very correctly said, private healthcare is very fragmented. There are small healthcare setups, there are big healthcare setups, and the primary healthcare setup, if you look at, and digitization costs money, and it doesn't always bring in a very great ROI proposition. That also we'll have to look into.
Thanks for that. It's very interesting, but I don't know if all of you are aware. In terms of telehealth, India has been running pilots. Many pilots have run for the last, I think, 10 years on telehealth. And most of them have been not very successful, especially in terms of scaling. But with COVID, suddenly we saw telehealth just take off, right? So we needed COVID to actually get telehealth to take off. But having said that, the challenge, Ruma, that I feel even in the urban areas, and we're working in some of the slum wards of Mumbai, and the small clinics, how are we going to bring them on board? That's pretty much going to be the challenge.
Absolutely, that's what I was trying to say. It's difficult.
You need to give us solutions. So what do we do? How do we bring them on board? I mean, or maybe any of the other panelists, if you have some thoughts, how do we bring the small providers on board? Because they are a large part, especially when you think about people living in low resource settings who can't afford good health care. I think that's going to be a challenge, and I'll leave that question open to you.
So probably it has to become more affordable. As we move forward, we'll have to look into it. The reason why they will not be able to, why the small healthcare primary care providers are not in a position to adopt this technology is the cost. Because the patient is not going to pay a single rupee more because we are digitizing it.
Interestingly, I'll just share with all of you out there, one of the challenges that we find is that most of the smaller healthcare providers operate in what I'll call the cash economy. And they have this general sort of sense that the minute you go digital, you come into certain amount of tax-related challenges too. So that's another piece which is probably making people hesitate, which we'll probably have to find a way. And I know that a lot of people are thinking about this. But let me continue to move on as the clock ticks. Let me move to my next panelist, Prabhat from Boehringer Ingelheim. And, Prabhat, very interestingly, in the last panel, we heard of the UPI moment for health, right? Now, I don't know, I hope that's going to be true. And I hope we're going to get that. But just coming to, if you think about service delivery, and if you think about healthcare workforce, what are the health system frameworks that we need to work towards to be able to move this forward? And I'd like to hear your thoughts.
So I think I'm a big fan of WHO health system framework, and I think it gives you a kind of a visibility that how you don't leave one important one. And let's say when we talk about health workforce, task shifting, we always will struggle to get right resources at primary level. And I think the primary level is the base for our healthcare system. Nothing can work without that. Now, some of the examples what we learned during COVID was, for example, training. Now, initially, before COVID time, unless you bring all these people together in a room, that was probably the only way to train this. Now, digital gives you these tools to kind of refresh their learning quite frequently. The second most important is, again, diagnostic and early diagnosis because of telemedicine and a lot of other things. But what is most important is continuum of care. And I think post-COVID, where we have moved quite a bit, is continuum of care, because now with assisted telemedicine or sending reports out from primary to secondary level, you can do something on that level. Two more things which is very critical is, some of the decision support system now, it has been few pilots, few years back on diabetes care, I remember AIMS had piloted something in Himachal in terms of using decision support system at primary level, so that physician who is treating chronic patients can get some insights from that. And I think with AI and a lot of other things, this can still is being used, but the issue is how do we scale it up? And the third is standardization. I think at primary level, many times is the standard of care, what a patient should get. There is a huge, kind of a difference that, and then let's say a type 2 diabetes patient can end up being a patient with kidney disease, because the kind of treatment that patient should have got, standardized care at primary level, may not be possible at some point of time. So I think the early screening, this whole training, the third is decision support system, standardized care. I think these are some of the way forward post-COVID that we can go. And as digital is a tool, if we start applying it every framework, there is something that is helping, even to the governance, for example. Now sitting in Delhi, a program can be reviewed quite intensively, even on under NHM framework or any program. Now these are some very good tools, either administratively, technically, we can, and these are being piloted, but I think the whole issue is that how these good practices, which is happening in one pocket, crosses that boundary and scales it up at a bigger scale.
Thanks, Prabhat. Girish, I'll come back to you because I'm still missing that transformation of the primary health center. And I'm thinking, primary health, when you think about it, it's not the primary health that some of us go to. But let's talk about, primary health for people who can't afford. How is digital going to transform that? If you could, and from your experience, you've seen some of this stuff. You set up a lot of this stuff. And I know that. That's why I'm bringing this back to you. And how are we going to scale it up? We're a large country, 1.4 billion people. We need to be able to provide equity in terms of health services. So some thoughts on that, Girish?
Yeah, thanks, Neeraj. I'll just lay out a high-level framework, how the primary care and secondary care, which is really can be transformed or put in place for the needy of the country, which is based on our experience. See, today, let us divide this thought process into a bigger chunk of what is the total health services, like the Ayushman Bharat defines. Any service you provide in healthcare, about 1,270 different services. That's a superset. And if you go and dissect and demystify that and put all the services in place, about 1,100 services comes under within primary and secondary care in the public health system definition, which is either it happens in primary health centers or in a block level or civic hospital or a district hospital. That is a level about 80 to 85%, 90% of the services are rendered. Now, whether it is a private or public, that superset is correct. Now, in that circumstances, there is one empirical formula I will give you based on our experience of treating about 50 lakhs patients. In a power sector, we talk about load. In healthcare, if we take any demography, whether it is city or rural India or even outside India, on a per day load is about 1 to 1.25%. That means if you take 100 people or if you take 1,000 people, there are about 1% and 1.25% of that day they need care. Today, if you look at it, in 30% of them, they go to some hospital-owned care and tertiary care. About 30 to 40% of them, they go to local primary care. The rest of 30 to 35%, if you take a 25,000 people population of required care that day, close to 7 to 8,000 people, they have to necessarily go to public health system. So unless you transform the primary and secondary care of public health system, you will not be in a position to address that. The biggest irony is more than 95% of that care is given free by the government. Now the biggest lacuna there is our citizens doesn't know how to seek care. So we ran a program, one simple program called Known Citizen Drive. Instead of saying we go and register patient in a below poverty line or a card or something, we said government need to know the citizens. So we ran a known citizens program and we created a model where in a week we can bring in 1.5 lakh people into the system, and which has really played a phenomenal role. And we are able to, by connecting, there are 4 points I will give you. This is the transformation technique. Generally, healthcare is delivered with a human resource and an infrastructure. Be it digital, not digital, anything, we believe that there's a doctor and a clinic, a procedure room and a technician. So there is always a human resource and infrastructure. That's the way the healthcare operates. We brought in 4 additional transformation layers to healthcare. One we call as a network. It's not a network of infrastructure, a network of everything. Network of infrastructure, network of people, network of process, everything. Second, we brought in something like process. In healthcare, the protocol and process is generally delivered by a medical scientist or a medical professional. But in rest of the other sectors, most of it is done by management people. So the first time we brought in reimagining the process in healthcare by a management team. Third, which is a people, very important part, not that doctor and nurses, paramedics can solve the healthcare problem. We looked at and brought in something called a digital workers. And what it means is, it unleashes a lot of our capacity. I'll give you one statistics. About 52% of specialist time is spent on a non-clinical activity. And 35% of his time is spent on administrative activity. If you unleash and give a digital platform on somebody else, a regular BSc graduate to do that work, then the specialist time gets freed up. In this model, network, people, process, and the last one, tech platform. That transformation layer we bring in, we can transform the public health system of the primary care. That's what we experimented in Karnataka, we experimented in Himachal Pradesh, that's what we did in Telangana. Amazing results. And we are working with NHA and ABDM whether how it can be replicated nationwide.
There you go. You hear from the practitioner who's done it, and I have been following your work in Karnataka as well as Himachal. Ruma, coming back to you. How are you going to improve? Let's talk a little bit more about the efficiency. In your mind, what have you seen to improve the efficiency at a primary healthcare level by using digital technologies, services, etc.? Where have you seen that happen, or where do you think is the sort of soft spot that we should be targeting quickly?
Again, I will speak from the provider side, and I'll again talk about the urban healthcare. I'm not getting into the rural healthcare at all. What I see, the efficiency will come, it's going to empower patients. As we are seeing, there's a paradigm shift when the treatment is becoming more personalized and moreover participatory. So digital health with its information primarily, if it provides authentic information to the patient gets empowered to take right decision at the right time. Then again, if the reports, the test reports are there with the patient available, by having those, and also with the information, talking to the peer group, they probably take a timely, conscious decision about moving towards the right healthcare. That's important. Thereby, what you do is, you tend to go to the clinician, the right clinician at the right time. That saves money, because it's not, I have gone somewhere, I understood something, then I got referred to somewhere. I think overall, if you ask me, it in a way empowers patient, where we are seeing that it's healthcare delivery at the primary level is becoming more participatory and more personalized. Again, if we typically look at the wearables, the things which are coming, the urban population are pretty, the Fitbits and all that stuff. People are wearing it. So that's again empowering people to becoming more conscious about their health. The preventive health is taking a step forward. So these are the essential areas I'm typically looking at where efficiency is being brought by digital health. Again, I'm telling you, repeating it, it's urban primary health care.
Do you think it's that different in rural, Ruma?
There is, because I also work in a space which is a tier 2 town. Of course, we run a hospital which is a 250-bed hospital. That's too different from metro city. People's expectation till date is different. You know, even if we make the reports available in an app, they still prefer to come down to the hospital, stand in a queue and take the reports. So it's different.
Thank you. Thanks. I've been looking at checking your pulse on your watch as you've been speaking, talking about wearables, you know. I'm looking at your watch, checking your pulse on it. Girish, how's it working? All good? Okay, great. You know, one of the conversations that we have in public health is that politicians, if they start giving wearables as a political maneuver, that would be very, very useful, because all of a sudden you'll have populations who are actually looking at their health, like many of us are. Okay, we are coming to the end of our session. I can see the clock ticking. I'm going to just shoot a very quick question to all of you, and with a 1-minute response. Maybe I'll start with you, Prabhat. So if there's one thing that you would focus on, you know, India, like I said, is a big country, you know, disparate population, you've got rural, you've got urban, etc. If there's one thing that you think you had a magic wand and you could fix, what would you focus on in terms of digital primary health?
I think at primary healthcare center, focus is more on prevention, right? And that is where giving power to patients or caregivers. I think digital tools have now shown how people can come together. They take control of, you know, their health conditions. And if there are so many WhatsApp groups, so many Zoom call, right? And we had seen a movement of self-help group in our country, right? How self-help groups have come together and worked towards livelihood. And I was reading somewhere now, you know, and we have Rogi Kalyan Samiti, many of such experiments that happened at primary level. I think one thing which can happen at primary level, a wish is that, you know, people, let's say with chronic disease where I'm talking more, is if these people can come together, if there is a group and they take control, they share their, issues, right time they get referral, treatment compliance, those things will start happening.
But you do know that WhatsApp groups can be very dangerous. Huh?
It is. But see, the issue is that, yes, it is dangerous, but, you know, you can't stop people be there. So a moderated group, that's why I'm saying it's a moderated, may not be a WhatsApp, any other tool, right, where it is moderated, but people have a chance to share with each other.
Great, thank you. Yeah, I think probably, especially for chronic conditions, as you talked about. Ruma, maybe the same question to you. What would be that one thing that you would want to sort of focus on? You know, we have budget considerations, we have challenges. It's a large country, like I said. Equity is at the center.
Yeah.
What would you suggest we do in primary care?
Maybe I would want to make the digital technology available for primary healthcare system more affordable.
And you think that would change the paradigm?
Absolutely. So the moment it becomes affordable, I think adopting the digital technology will become more and more. The providers will then start. Actually, in today's date, if you see, even the providers are not very much. If we talk about the entire segment of the provider, they all are not very keen in getting into that space. Again, cost matters. As I was saying, it doesn't really give you a direct return on investment.
We're going to have a parallel conversation because we have, ABDM has got pretty much free tools to help digitize smaller
Again, it will take time because the awareness has to come, as majority of the people, they will have to know this is available and I can really, use that.
True, and that is what
I'm not saying that work is not happening. We are moving towards that, but this is still
But it's not just affordable. I think the awareness is critical, as you said.
Yes, absolutely.
Girish, you want to answer the same question? I'm sure you have some solution for us.
See, your question is very simple. If there is a magic pill or magic you have, what is the one big problem you solve for the healthcare? See, there's one problem which is access and availability. I'll divide that into 3 blocks. See, we tell that we have, for every 1800 people, we have 1 doctor. That is true if you're sitting here in central Delhi. If you move about 20 kilometers away from this or 50 kilometers, it increases by 10 times. And then there are top 36 specialization if we take, then it increases by another 10 times. That means what happens, that 1:2,000 becomes 1:2 lakhs. This is the first problem I would like to address. Second problem of the same connotation, I believe digital only can fix. The current care method is episodic in nature, one episode to another episode. Second is it is disjointed. And we have somehow come into a model, care only can happen in the hospital. Now this is the second area I would like to address it with digital.
You were allowed only one, huh?
No, that's why I took a rain check from 1 to under 3. Then the last point within that is the chronic diseases which is coming into India in a big way, and which is huge problem for us. So all the three put together as one big problem we are having, which is access and availability we call. So this is what I would like to address.
Thank you. Thanks a lot. Thank you for a fantastic conversation. I think, maybe I'm going to take the liberty of answering that question also. If I had a magic sort of a wand, what I would want is digital population level screening.
Reimbursement is another one. I think that's, if there were insurance companies in the private sector, or there is a payer to that which is not the patient but someone else which is reimbursing, then I think there's a possibility for better adoption. And I think what you articulated as well, Gautam, was about the cloud and the security concerns. But I think that's something which we have to also think of. There are other industries where there's also sensitive data and they're able to work with the cloud, so why not healthcare? So I think we need to jump that barrier very quickly and kind of put that trust into cloud and the servers and whatnot. But I think as a manufacturer, these are some of the things which I want to do, is that how do I build trust? How do I allow for a better training program which allows for workflow articulation on a return on investment, I think is going to be key to look at. And last is really to give that, again, to demonstrate that cloud does work and it's not only limited to healthcare where it is.
Thank you, Sumit. We've had wonderful comments from the panel. I think we have time for maybe one or maximum two questions if anybody from the audience has a comment or question. Anyone? There's a gentleman there. Please introduce yourself and ask if you're asking any panel member or it's open.
It's an open question. My name is Shrikant Srinivasan. I represent in this question myself, not the company. I represent GE Healthcare anyway. I wanted to ask in everyone's mind and on the panel and also to the room in large, who owns patient data? Who owns the patient's data? My own data, my health record, who owns it?
Ideally, the patient owns it, but the custodian is the hospital.
Okay. And so the second thing is, how do you democratize that data? Is there a so-called security issue there?
Currently, I can just speak and maybe I'll ask others to say. Currently, for your perspective, if a patient data is required by somebody as a hospital, I cannot give it to anyone unless the patient asks or authorizes somebody to ask, or if the court tells me to give it. So that means today the patient data is his or hers, but I can give only to him. So I'm the custodian. So that is why I clarified that. And how to give that assurance or I missed the second part. What is it?
No, I just saying that is there a possibility for us to democratize the data anonymously?
No, but that is happening in research when it is happening.
Got it.
But then it is used for, research and other clinical papers and analysis and all that. But you can't use it for individual treatment. That I think Dr. Alex wants to.
Yeah, I think this is one of the mission of ABDM, that we can use the data, it's anonymous, and as Gautam said, the patient is the owner and without his consent it cannot be it cannot be. I just want to add a very important point I missed in the solution to my question. We are actually in talks with the National Health Commission, the what is it called? The Ministry of Health and Family Welfare, to try and get technology introduced into the nursing, medicine, etc. We've been successful in introducing climate change and communication. So I think we all need to work together because I think this is important.
Last comment.
So since Mr. Srinivas mentioned about data, who wants it, there's something what we are seeing in the digital sphere is also about, the source code for various applications, and some of these tenders that we've seen recently where the government or, the tender conditions says that the source code has to be transferred to the, authorities or the regulators. Now the big question is, what does the authority do with these kind of source code? And again, brings back to the question of what happens to the source code and the consequent data, because government says they would want to have access to that data. And similarly, the tenure of these PPP tenders on the healthcare is just about 3 to 5 years. So by the time you're implementing and the solutions get deployed, you have to hand over the source code and the data to the government. So again, I think from a suggestion perspective, we'd love if these tenders are for 10 years, at least people get time to implement and then basically, build the solutions.
Thank you, Yash. Our time is up, but thank you for the wonderful comments and insights from the panel. Thank you.
Thank you. This panel, in fact, has been dot on time. Thank you for that. And 50 trees we are going to be planting on behalf of our speakers at AIMS, Deoghar. And now, ladies and gentlemen, we have the concluding session of the day, the keynote address by Mr. Rizwan Koita, the co-founder of Citius Tech, Koita Foundation. Citius Tech is one of the fastest growing healthcare technology companies, and Mr. Rizwan is an entrepreneur. He's a philanthropist with a passion to leverage emerging technologies and business process innovations to have a more meaningful social impact. So at the day end, we look into, again, leveraging on technologies towards more making a social impact. And we have Mr. Rizwan leading us in this talk. Thank you.
Okay, thank you very much, everyone. I guess being the last speaker of the day is not the best opportunity for me to get all your mind share. But before I get started, I have 3 confessions. First of all the points that I'm going to make, likely we've had an amazing day and lots of really bright speakers. So a lot of the points have probably been covered. The next confession that I have for you guys is that amongst all the speakers you've heard, I probably know the least about what's happening in India, because a lot of my experience in digital health has happened through course of my 20 years of experience outside of India, largely running Citius Tech, which focuses mainly on the US and the European market. Nevertheless, my last 18 months of working in India has been very insightful. And I've learned a few things about what is happening here, and I would love to share, my thoughts and insights with you guys. Yeah. So, one second, this is going too fast. Okay. So, I'm going to skip this slide. This is, again, a very obvious slide that healthcare is very complex. And doing anything in digital in healthcare requires a lot of stakeholders to work together, both in the public sector as well as in the private sector. And there is a significant amount of disparity in the level of sophistication, in the ability to invest, in the ability to understand what's happening in the digital health space. And we must all view this as a marathon and plan for the digital health transformation as a marathon and not a sprint. And it doesn't matter whether you're a large company or a startup. If you put too many resources too quickly and you burn out, then you probably cannot hope to win a marathon. But if you recognize that it's a marathon and you pace yourself well, then there is likely opportunity that there is a lot of reward at the end of it. I thought this slide it would be important for me to share on a global basis what we have seen work well and what we have seen not to work well when we look at our experience with digital health on a global basis. So what are the things, let me first focus on things that we've seen work well. So first of all, I think it's really important that if we have to make progress in digital health, then we have the ability to reduce complexity for all stakeholders. It's the ability to reduce complexity for healthcare technology vendors so that they are not building custom solutions for each of their clients, and each of the clients are not requiring them to do their implementations in their own way. So defining standardizations in data sharing, continuity of care, even some of the use cases that different stakeholders, I think goes a very long way. The second thing is that many healthcare providers, it doesn't matter whether you're in India or you're outside of India, often don't have all the means to be able to invest, and providing some level of financial support either through compliance incentives or capex or something like that becomes very important. The third thing that we have seen is aligning with insurance companies and creating one of the big stakeholders that benefit due to reduce fraud, waste and abuse of healthcare going digital are insurance companies. And when we are starting to talk to insurance companies, many of them are extremely motivated, excited, and they don't mind providing certain benefits to partners or hospitals who go digital. And that could be something as simple as just putting their claim settlements on a priority and reducing the turnaround time for claims. So e-claims get settled faster than traditional claims can go a huge way in creating financial incentives. The next thing, which again is a very useful insight that we found, is that the level of maturity of digital health is very different among different stakeholders. So if you look at the previous slide, what you'll notice is there are some entities which are corporatized. So for example, technology vendors often work, it doesn't matter whether it's small or big, they have a more corporate type structure. There is a CEO, there is a certain head of technology, there is an engineering team, etc. If you look at labs and pharmacies, they tend to be more structured. Hospitals are often, either government hospitals, a lot of hospitals are trust-owned, and the key decision makers often are doctors who are not all, they don't have a reporting hierarchy, and therefore, what we've learned is that if we are able to push digital health in the vendor and the service provider community, then that has a huge percolating effect. So the way, whether you are looking at an industry body or the government, ensuring the initial focus is on the vendor community and the service provider community gives you a much larger bang for the buck than targeting direct doctors or direct hospitals who are often much more challenged in their adoption. And creating some kind of financial incentive, I think we spoke about it earlier, but even for consumers, creating an incentive, especially in a very price-sensitive market like India, can go a long way. So imagine, for example, we could have the lab companies who could share lab data on your Aadhaar ID and not give you a printed document. It will save them the cost of printing, the cost of putting that paper into an envelope, and the cost of posting it or delivering it to the patient. And a small part of that benefit if it went to the consumer, and the consumer was told that there's a 25 rupee less charge for a 500 rupee or a 1000 rupee lab test if you are willing to accept an Aadhaar linked record. You're going to see a lot of consumers who will say, hey, you know what, if I can see it on my phone anyway, I look at the piece of paper and I'm going to probably review it and I'm going to junk it, I can save 25 rupees there. So I think that it goes a long way in thinking creatively on how to create, even if it's very small, financial incentives from a consumer perspective. What are the things which we have not seen work well, okay? Just going to a doctor or a hospital and evangelizing about the fact that healthcare will become better because you go digital, somehow we found that it didn't work very well in the world, okay? And I don't know, maybe it could work well in India, but that itself is not a compelling argument for many doctors and many hospitals where there is a real cost and pain associated with changing clinical protocols, changing the way you work, and so on and so forth. What we've also not seen work well is expecting consumers to suddenly become so actualized about their health that everybody is going to now start maintaining their PHR. And big companies around the world have tried to come up with personal health record solutions and strategies, and most of them have not been successful. The ones who support chronic diseases, there's more progress. I'm diabetic, I have got heart failure, I'm a patient of cancer, I'm likely to think of my health. But if I'm a 25-year-old adult and I'm very healthy and you're expecting me that I'm going to now start suddenly getting so interested in my healthcare that I'm going to keep every record of mine proactively, then, a lot of times we have found it hasn't worked well. And the last thing that hasn't worked well is, lots of different people doing work in an uncoordinated manner without a certain a common theme or common objective between government, between industry, a lot of dissipated energy, but not necessarily as much to show. So the summary of all that is that if you really want to improve digital health, then focusing on what is true ecosystem efficiencies and ensuring real financial benefit of the stakeholders become really important. And that kind of brings me to the last slide. So what does all that mean for government and industry? And what I've done is I've kind of broken this up into sort of three heads. One is around innovation and research. The second one is around regulation incentives. And the third one is around capacity building and marketing. And I'll kind of go through each of these points in some detail. First of all, there is a real need for digital health innovation in India. A lot of areas, Western solutions or solutions that have worked really well in US and Europe will just not work in India. They will not work in India in digital health because either they were over-architected for the Indian market, they are too expensive, or they are not necessarily aligned with the workflows that work on the ground in India. So it's important that we create a digital healthcare startup ecosystem. And the way the government and industry can work is, when we talk to startups, we find one of the biggest challenges is that early adopters become a problem. So how about creating an ecosystem where we have doctors and hospitals who are open to piloting new technologies, and if we could create that ecosystem and make that available to the startup community, it will go a long way in accelerating that. The other thing that I think government and industry can do is just bring tighter integration between research institutions, healthcare organizations, in some way to be able to accelerate. We work very closely with IIT Bombay, we work with many other academic institutions. There are lots of really bright kids there who want to do stuff in digital health. If only they can find internship opportunities, if only they can somehow get connected to small companies, large companies in the digital health space. I think there's a lot of talent out there, but it's very difficult to find motivated companies and motivated individuals and young engineers to get connected in absence of some framework. Yeah. The next thing I think that the government and the industry can do is really look at regulations and incentives. So coming up with digital health guidelines, our foundation is involved with NABH, and NABH is developing a digital health standard. I think that is a great first step. But I think we need to do more of that. ABDM is a phenomenal opportunity for us to standardize and create a certain set of common standards for transporting data across one hospital to the other, between doctors, between labs, and so on and so forth. There is a new claims standard which is getting rolled out, and that will again go a very long way. And the last point I want to make is around capacity building and marketing, which is just around improving the awareness levels of all stakeholders. At the end of the day, if I'm a doctor or I'm a nurse or I'm a lab or a pharmacist, probably got educated in an era where there was no digital. And I hear a lot of these buzz and I get a lot of these email and all of that, but still there's a lot of apprehension. So to build a credible capacity building, training content, which is not too complicated, no well-practicing doctor has time to sit through days and months of training, but I don't think we need to give them that level of training, but even a couple of days of training or a few hours of training, if done right, can really solve a lot of the apprehensions that exist in the mind of doctors and hospitals about using digital health. But it will all depend upon the sophistication and the quality of how the content is getting built. If we do it without applying thought, then either we are pitching it too high and it's sounding a lot of more sort of technical gibberish that doctors will not want to go through. And if it's pitched too low, then it won't achieve the objective. So how do you really build the right level of technical content, which is just right for a doctor, probably in their 40s, 50s, and 60s? And in the same way, how do you come up with new curriculum which can be embedded into an MBBS program, into sort of medical education, so that the next breed of doctors who are going to be, and nurses who are going to be hitting the market already come pre-built with a certain degree of digital health knowledge. Yeah. And finally, I would say that all of that is going to hinge on the fact that consumers are motivated in supporting this program. And, I'm going to say, I didn't have a slide on it, but I'm going to say something. A lot of medicine in India happens through cash transactions, and we've heard this before, right? If I'm a doctor, it's costing me 30% tax if I start reporting all my transactions, right? So what is the revenue loss I should be having to compensate for that, right? And my number in my mind is, if somewhere between 10 to 15% of my patients who are walking in demand that I have a ABDM compliant solution, and if I believe that I may lose 10 to 15% of my revenues, then I have to make a real trade-off between paying a 30% tax or a 10-15% drop in revenue. So unless we don't link our sort of market awareness to what is the income tax rate, I think we will be missing the plot. Okay, so with that, I'm going to conclude. A great day. Thank you very much, everyone. And it was wonderful spending time with you guys today.
Thank you, Mr. Koita, for your presentation, how to improve our digital footprints in the healthcare sector. And somewhat his presentation, as we have the three words: collaboration, integration, and reimagination. It fell right in place. We need to collaborate with the best, we need to collaborate with the academicians and the various research institutions. When he spoke about the integration work which is having in silos, we need to integrate that, and reimagining healthcare with the digital. That is, we're building the digital ecosystem. So thank you for that presentation. One word, Mr. Siddharth has an announcement to make.
I have a very quick announcement to make. I know we have a very vibrant set of startups. If you just take the stairs down, you will find in Regency 1 to 5 a number of startups which have been patiently waiting. This room needs to be set up for the talk with Dr. Soumya Swaminathan and also the dinner and all other arrangements. So for the next hour or so, I sincerely request all of you to kindly spend some time with the startups. Let them talk let them speak to you, interact with you, and then please come back here by somewhere about between 7 and 7:15, if that is okay. So it's a request. Please use the time, and they will be very encouraged. Thank you.
Thank you. You made my work easy. So that was, we are drawing curtains right now, day 1. Tomorrow morning we are going to be starting at 10 o'clock. As mentioned by Mr. Siddharth, just little steps down downstairs in the basement, we have the innovation hub. We have the innovators, the tech guys with their technologies and digital solutions which can support digital health. We are requested to kindly please visit them. 7:30 we have a session where Dr. Soumya Swaminathan, who is the chairman of the MS Swaminathan Research Foundation and the former scientist at WHO, is going to be joining us for a special session. Tomorrow morning, starting here at 10. So enjoy your evening and further happy productive sessions.